Greetings, I'm Keith Horvath, and I'm here today to talk to you about a new reimbursement method that the Center for Medicare and Medicaid Innovation is planning on launching in about a year that will impact cardiac surgeons across the country. Specifically, I'm talking about the Transforming Episode Accountability Model. This model has several important key elements. It is, as noted, a mandatory model, meaning if you have been selected to participate in this model, you have no choice but to do so. It involves 5 different surgical procedures, coronary artery bypass grafting being one of them, but also includes lower extremity joint replacement, major bowel procedures, surgical hip and femur fracture treatments, and spinal fusion. This is a 30-day episode bundle, and it's important to remember that because those are the costs that are included in the model. The model will start in January of 2026 and extend for the ensuing 5 years to December of 2030. There are 3 different tracks within the model. The first track has no downside risk, but has lower levels of reward for that first year. If you start in track 1, you will then be moved into track 2 for the subsequent years. Safety net hospitals can stay in track 1 for those first 3 years, and they then also will be moved into track 2. You can opt to start in track 3, which includes higher levels of risk and reward for that entire 5-year period of time. As is the case with most value-based care models, there are quality measures that are part of this. There are 3 quality metrics for the first year of the model, with some to be added in the second year. Those 3 for the first year are the CMS PSI 90, the hospital-wide all-cause readmissions, and for total knee and total joint replacements, there's a patient-reported outcomes measure. In the second year of the model, there are 2 hospital harm indices, falls with injury, and postoperative respiratory failure or reintubation rates. And the third additional metric to be added in that second year is risk-adjusted mortality, or as is stated here, a failure to rescue. So who's eligible to participate in this model? Acute care hospitals located in 188 core selected statistical areas. These acute care hospitals have been chosen at random by CMS. But other acute care hospitals can opt in. But if you do, you have to have already been participating in BPCI Advanced and or CJR. And if you do opt in, you are then in the model until its end. You can't opt out voluntarily. So to expand on that eligibility, there are acute care hospitals, there are safety net hospitals, rural hospitals, Medicare dependent hospitals, sole community hospitals, and essential access community hospitals. Hospitals in the state of Maryland are excluded because of their ongoing waiver demonstration project with CMS. So these core-based statistical areas encompass these regions on the map. And within those regions, there are a variety of the number of hospitals that will be included. This is important because the pricing and the targets that you are trying to achieve are going to be regionally based. So almost 750 hospitals have been selected for this particular model. Getting into a little bit more detail on the tracks. For track 1, and this is going to be for performance year 1 for most of the acute care hospitals, safety net hospitals can stay in it for an additional 2 years. It is upside only, so there's a 10% stop gain, so there's a little bit of a limit on that upside. But nevertheless, there is no downside risk in being in track 1. There is a quality adjustment of up to 10%. In track 2, which is where everyone will be transitioned if they start in track 1, again, except for those safety net hospitals, there is 2-sided risk. So there's upside and downside risk that's at a 5% stop gain and stop loss margin. And there's a quality adjustment of up to 10% on the positive side with a 15% adjustment if the quality results are unfavorable, and therefore those funds would be withheld at the time of reconciliation. And finally, there's track 3, which you can opt into from the first year of the model, and it does include two-sided risk with a 20% stop gain and stop loss. So again, higher upside, but also increased downside risk. And there's a quality adjustment of up to 10%, meaning as we saw in BPCI Advanced, there's a 10% of the reimbursement that's withheld. Depending on your quality score, you get a portion of that. If you have a great quality score, you get all of it. If you don't, you get less of that 10%. So what constitutes an episode? Well, it starts with the procedure and that acute care hospitalization. And that hospital then bears financial accountability and is responsible for the care coordination. But the 30 days of that episode actually starts at the point of discharge. And it includes the DRG and the outpatient HCPCS codes. And then over the course of that performance year, there is evaluation of what was spent, and there's a reconciliation that occurs. The exclusions to those costs are anything related to oncology, trauma, medical admissions, organ transplant, ventricular shunts, any medical device pass-through payments, drugs or biologics that are paid outside of the DRG, and any of the additional add-on payments. As noted, there are a number of different quality measures that all cause readmission, and the CMS PSI 90, which is a composite of 10 different measures, are for all team episodes in that first year. For the lower extremity joint replacements, those patients will participate in a patient-reported outcome quality measure, and that will be also attributed to those procedures in that first year. Those measures will all continue throughout the entirety of the model. In the second performance year, falls with injury and post-op respiratory failure, 2 measures of hospital harm, will be added as quality measures. And then there is a risk-adjusted mortality rate that will be included at that time. The target prices are very important regarding success or failure in this model, as is the case in any value-based care model. So they're going to use those regional baseline spending measures, and they're going to standardize those. Those will be weighted over the 3 years prior to the start of the model. So the year 3 will count more, if you will, towards that regional standardized spending and contribute more to the calculation of the baseline than year 1. As you can see on the bars on the bottom of this graph, 50% of that baseline spending will come from those year 3 costs. All of that will be blended together to come up with a benchmark price. Benchmark price is then multiplied by a prospective trend factor and a normalization factor, 2 different abilities by CMMI to make sure that they're controlling the overall benchmark prices. And then they take their discount or their guaranteed savings out of that benchmark price at a 1.5% to 2% rate. Note this was an advocacy win for the STS in that the cabbage discount factor was supposed to be 3%, but it has now been cut to 1.5%. All of that then creates a target price. And if you stay under that target price, you keep those savings. If you're over that target price, you have to pay CMS the difference. So that's a very brief overview of the new team, this reimbursement methodology that CMS is going to apply for coronary bypass graft patients. Thank you.